today. And feel free to let me know where you're logging in from. Say hello to everyone. We have an international audience. We're going to get started in just a little bit. Excellent. We have people logging in from Romania, Arkansas, Texas. This is epic. And if you are excited for today's review and you want to share it with a friend of yours, colleagues, your class, here is going to be the live stream link. I'm going to post this on my Instagram story right now as well, but feel free to share this live stream link if you are going to be joining this session. And we'll get started in just a little bit. Excellent. And if you have just joined us, feel free to say hello and where you are logging in from. Excellent. We'll give it just about 2 more minutes as people log in. All right, we have people from Phoenix. Excellent. All right, well, if you haven't done so already, I would encourage you all to open up your chat box, say hello, keep the chat box open. I got my chai tea here for the session. And we're going to get started in just about a minute. We have people logging in still. Great. And if you have not yet shared the live stream link, feel free to tag me on Instagram, YouTube, share this with your colleagues and friends. It's going to be a very high yield review session today. So I am super excited. Before we get started in just about a minute, can you all say yes into the chat box if you can see my slides, see these annotations? Excellent. All right. So audio, visual, everything is good. Great. Well, let's go ahead and get started with our review today. For those of you, if this is your first time, I want to welcome you all to the HyGuru family. And if this is your second, third, or 100th webinar with me, a warm welcome back. My name is Rahul. I'm a practicing pediatric critical care physician, and I'm also a extremely passionate medical educator. I help students just like you kick ass for the USMLE Step 1, shelf exams, comp, Step 2 CK, and everything in between. Feel free to connect with me. Many of you have already signed up for my courses, which I offer at HyGuru.com, but we will be going through some of those nuances and details if you're interested towards the end of today's webinar. So I know that there are so many resources out there. There are many question bank resources out there, AMBOSS, UWorld, etc. But I want to take a few minutes just to talk a little bit about what I think makes HyGuru extremely unique. When I started HyGuru, I wanted to really focus my whole curriculum and the lectures on evidence-based learning science. HyGuru is a strategic active learning approach. And throughout my videos, what you're going to be seeing is an emphasis on vignette-focused learning. My goal is for you to not slam the spacebar and just get small details. It's actually for you to understand how these exam questions are written and what you're going to be seeing on Prometric exam day. HyGuru really focuses on integration. What you'll see today is we will be taking a singular concept from an organ system and see how it applies to other organ systems. For example, we're going to be going through all of the neoplasms and associations related to smoking. So I want to integrate knowledge as I go through today's session and in my courses. Third, I focus a lot on test-taking strategy. It's important for us to have a system so we can have a consistent output. And finally, I know that this is not just a content, question bank, or test-taking strategy grind, but it's a mental grind as well. And I want to make sure that I stay dynamic throughout all of my lectures so that we can focus on peak test-taking psychology so you can perform on exam day. So when I work with students one-on-one or when I am tasked to come to a medical school, one of the things that I center myself on is the triad of USMLE Step 2 CK preparation. It's all about making sure you have good accountability and study scheduling, making sure that you are leaning into questions with a clinical reasoning framework. And like I said before, it's all about staying positive throughout the journey. Sometimes you're going to be getting some lower blocks. Other times you're going to do extremely well on the NBMEs. Understanding that this is a nonlinear process and there are going to be ups and downs is essential for you as you go through the shelf and Step 2 CK process. Most importantly, and I see about 200 people joining me today, which is absolutely phenomenal, HyGuru is a lifelong learning community. It is a global community that all of us can connect via because we have that common thread, and that is succeeding on the USMLE. So in the past year, 2024, this has been some of the success stories that I have been fortunate to be a part of, both from a one-on-one tutoring standpoint, as well as being a part of my courses. And I'm so excited to have you join today and share in my passion and energy. Now, many of you may be seeing on my YouTube channel that I have a growing top NBME shelf concepts or Step 2 CK lecture database. And here I have my highest yield lectures posted. It's a short sample. It's only about 5 to 7 videos. This is a great sample if you are going to be interested in getting kind of the full comprehensive review of internal medicine, peds, surgery, etc. I have a rapid review Step 2 CK course, especially if you are going to be going through your shelf exams or you are near your dedicated study or in your dedicated study. This rapid review course is essential because what I do is take all of the highly tested concepts from NBMEs and I synthesize it into an active recall review. What I've also done with many of my lectures is, as you can see here on the bottom, I've mapped some of the highest yield questions you can engage in after I go through a certain concept. So this has been an innovative approach. You can sign up on HyGuru.com. And what I will do at the end is open up to a question and answer just to help you guys during your shelf and Step 2 CK preparation. At the end, if you stick around, we'll be going through that question and answer. And then I can also, at that time, answer any questions you have about the course. But first, what we're going to be doing is starting off our family medicine review. We are going to be focusing primarily on the USPSTF screening guidelines. This is also going to be relevant for those ambulatory medicine questions under the shelf tab in your UWorld question bank. So what are we going to be covering over the next 50 minutes to an hour? We're going to be focusing on key definitions for preventative health. Everything from primary to quaternary screening prevention. I'm going to provide you a test-taking strategy so that then you can employ this when you get preventative health questions. And then we will be breaking down the USPSTF guidelines in a very integrated way. First, what I'm going to do is I'm going to be separating it by age and gender. And then second, what I will do is break it down by organ system. And I'm going to be just hitting you all with vignettes so we can apply the USPSTF guidelines rather than just rote memorize them. There are some nuances with age and certain risk factors. So if I create a framework for you all, then we can apply it to relevant cases. And then finally, there is going to be a focus on vignettes, especially the vignettes that you will see on NBME exams, as well as in your high-yield question banks. Now, many of you may be studying also for the family medicine shelf. And I just wanted to highlight the family medicine shelf content specification outline. What you see here is the breakdown of the NBME family medicine shelf. And as you can see, many of the questions are going to test your knowledge on adulthood, preventative health, and family medicine concepts. There is a small percentage that is focused on child and adolescent, as well as geriatric. What I also want to emphasize is the fact that the family medicine shelf in particular is chock full of MSK questions. So what I would do is if you have, for example, your UWorld or AMBOSS question bank, you should review specifically the MSK questions in depth, because as you can see, up to 20% of your family medicine shelf is going to be MSK. And if you YouTube 100 concepts in MSK, I have a nice step 1 review that I still think is very relevant for your shelf, or step 2 that you can watch right before your family medicine shelf. The other component that I want to emphasize here is our focus for today, health maintenance. It's about 20% of the questions that you will see on your family medicine shelf. So I hope that this overview and outline helps you tweak your studying as you're getting closer to your family medicine shelf. Remember, if you're in dedicated study for the USMLE, you will be getting ambulatory questions, and that's the focus of our discussion today. So before we do get started, I do want to provide you all a nice link that you can use as a handout today. You can download it on your iPad, print it out after the session, or pull it up on your computer or device. Feel free to open up your chat box right now, and I am going to be dropping in a high-yield PDF link. If you're watching this later on, I'm going to put this in the video description, but this link is going to have the overview of all of the USPSTF guidelines updated to 2025. There was recently, just last week, the Osteoporosis recommendations that got a little bit tweaked. We're going to be covering that. But if you guys don't mind letting me know, does this link work when you click on it? Go ahead and type in yes if you are able to access this link. Okay, Fabiola, Preeth. Okay, excellent. Wonderful. Thank you guys so much for following along with this link. And again, I do have a download link as well that is right underneath the USPSTF guideline handout that you can then just drop to your iPad or tablet and annotate with me. All right. So with that, we're going to go ahead and get started. Is everybody excited to get started today? See a lot of yeses from the prior question, but I hope that that is yes again. All right. Anushri is, Nader is, Yosra, Isaiah has a let's go. Excellent. Well, let's go ahead and get into our first question today. A medical student is participating in a health fair. The student is particularly interested in understanding prevention to optimize his patient's health. Which of the following best describes an example of primary prevention? A, lipid lowering therapy. B, counseling on smoking cessation. C, hemoglobin A1C monitoring. D, colonoscopy. Or E, reducing polypharmacy. Go ahead and type your answer into the chat related to primary prevention. Excellent. If many of you are saying B, you are absolutely correct. Counseling on smoking cessation. Let's go through this pyramid of the prevention concepts. The USMLE is going to give you at times either a drug ad or some sort of experiment-based question, and they may ask you to integrate these public health or epidemiology concepts. So these definitions and the examples are going to be very high yield. Let's go through this. Primary prevention is what our question was talking about. It is preventing disease onset. This is a lot of your counseling and lifestyle modifications. Before the disease even starts, we want to nip it in the bud. So an example would be counseling on healthy diet and exercise. Now, what about secondary prevention? Secondary prevention is going to be a screening test. This is going to be where our colonoscopies, mammogram, pap smears are going to be. These are, again, the USPS or United States Preventative Task Force screening recommendations. These are what you're going to be tested on your exam day. Secondary prevention is screening. Tertiary prevention is treating. This is going to be where you are going to treat a disease that somebody has to prevent morbidity. So what's an example of that? It is going to be, for example, monitoring hemoglobin A1C or a urine analysis if somebody has type 2 diabetes. So the goal of tertiary prevention is to treat the disease and make sure you understand the complications of the disease so that then you can prevent sequelae. And then finally, we have quaternary prevention. And the quaternary prevention is to essentially prevent harm. And that is going to be preventing over medication. So an example is, let's say a diabetic on your exam question is going to have recurrent hypoglycemia. They're either on insulin or oral sulfonylurea. Quaternary prevention is discontinuing the oral sulfonylurea or reducing the level amount of insulin medication you're giving the patient so that then they have less hypoglycemic events. So quaternary prevention is quitting unnecessary medical interventions. Now, if you subtly look at what I did as an educator, I put a green light or traffic light type of configuration. Tertiary prevention, stop. You already have the disease. Secondary prevention, that's screening. And then you have green light, which is primary prevention, preventing the disease onset. All right, let's go ahead and apply this knowledge. A 28-year-old female is diagnosed with gestational diabetes. The OBGYN provides recommendations to monitor her blood glucose checks throughout the week and log it in a diary. Which of the following disease prevention strategies is most likely employed in this patient who hint already has gestational diabetes? Go ahead and type that into the chat. Primary, secondary, tertiary, or quaternary. Excellent. And if you're saying that this is tertiary prevention, she has the disease already, and we are doing things surrounding the gestational diabetes, such as preventing sequelae by logging the blood sugar, that is going to be an example of tertiary prevention. Excellent work. The other very high yield concept the USMLE likes to test you on are characteristics of the ideal screening program. They may give you an experimental question and ask you which of the following is most likely in this screening program or related to the screening program. What you have to know is that screening programs have to be related to common diseases. These diseases should have a long asymptomatic phase. For example, colon cancer, cervical cancer, these are all very slow growing neoplasms. Second, this actual disease has to be correctable if identified early. It cannot be subject to lead time bias. Lead time bias is where you detect the disease early. However, that doesn't necessarily modulate or alter the ultimate prognosis. If I end up screening for Creutzfeldt-Jakob disease or a prion-based disease early, well, yeah, I can catch it 5 years before, but there's nothing I can do to modulate the mortality, which is high in Creutzfeldt-Jakob disease. So prion diseases, there's not going to be any screening. Why? Because it's a rapidly progressive disease, doesn't have a long asymptomatic phase, and there's no real treatment for those prion-based diseases. The other high-yield characteristics is that a screening test must be related to a disease that has high prevalence in the screened population. Just like many of the public health interventions, we have to have optimal cost, and the screening test should have a very high sensitivity and specificity. Let's go ahead and go through this biostats concept. What the USMLE will do is provide you two major graphs. The first graph is going to be known as the area under the receiver operating curve. This tells us whether or not we are going to have sensitivity or specificity and plots it so that then we can figure out the characteristic of that screening test. So here we have on the x-axis 100 minus specificity. And on the y-axis, we have sensitivity. So the ideal screening test needs to be in this upper left quadrant. If you don't know anything about AUC curves, you just need to know that the upper left quadrant is the most ideal. But if you look at the axes, you see that this upper quadrant has a high sensitivity, and because it is 100 minus specificity, it is going to have a high specificity as well, because let's say that specificity is 99. Well, that then shifts the x-axis towards a lower number. And as you can see, left upper quadrant under the AUC curve is the optimal for a high sensitivity and specificity. The other component that the USMLE likes for you to know is a question related to the set point. Now, here is going to be a curve that shows us test results relative to the frequency of the disease. What we notice here is that the dashed line is going to represent diseased individuals, whereas the solid line is going to represent non-diseased individuals. And you can see at choice B, this is going to be the best sweet spot for a screening test. At level B, you have a balance of sensitivity and specificity. But let's go through this NBME question. If a screening tool is changed to detect prostate cancer at a much lower threshold, so rather than saying prostate cancer at, for example, a PSA of 8, they're going to say a PSA of 6 now defines a higher risk of prostate cancer. If the test was shifted to a lower threshold, what parameter would change? And so what the answer would be in this question is if we are going to lower our threshold, we are going to then be capturing more people with the disease. So a lower threshold means that you capture more people with the disease. And that's extremely high yield for us to know, because what that means is that we are going to increase the amount of sensitivity. So if you capture more people, you get a high sensitivity. And if you get a high sensitivity, you get a low false negative. That means that if I get a test, it is going to definitely capture me. I will not be classified as falsely negative. This is extremely important because in this curve, we see here that level A is going to be where you're going to get more sensitivity. So lowering a threshold of the test captures more of the population. You become a lot more sensitive. And as a result, you are going to get higher sensitivity with less false negative rates. All right, so this is going to be the core of our discussion today. Let's go ahead and break down this timeline, capturing all the highest yield USPSTF guidelines. I updated it based on the most recent A and B recommendations. These are the ones that are highly tested for your NBME and family medicine shelf questions. And again, if you have missed the handout, I've put it in the chat box right here. All right. Starting at 18 years of age for adults, you are going to start screening for blood pressure. What you also have to note is that blood pressure or hypertension can only be diagnosed as essential hypertension if you have more than one reading. And we'll talk about that in just a bit. You also are going to start depression screening in adolescents, particularly when they are 12 years old. In my adolescent clinic as a peds resident, we started screening because those children were getting into middle school and high school, all about thoughts of sadness or suicidal ideations. You also will be starting to screen patients who are at high risk for STIs. But one of the interesting recommendations is that the USPSTF is going to recommend HIV testing starting at the age of 15. And this is going to be at times irrespective of your risk status. Now, speaking of risk factors, if you have a teenager or 18-year-old young adult that is going to be obese, is going to have a family history of diabetes, or let's say that they have acanthosis nigricans, you're going to be doing a fasting blood sugar as well as a hemoglobin A1C starting much younger than the prescribed mid-30s recommendation of screening for diabetes. So you start diabetes screening earlier for 18-year-olds who have a strong family history, who are obese, and who have signs of insulin resistance. This is similar at the age of 20 for, again, patients or young adults who are at risk. Maybe they have obesity, they have a hereditary dyslipidemia, or a strong family history of coronary artery disease. You are going to be screening for the lipid disorders using a fasting serum lipid panel. And here are going to be some of the general recommendations in terms of thresholds that you can see here. What I want to do is I want to say that the USMLE Step 2 CK makes it very obvious with these screening recommendations. So don't stress too much with these nuances. Just focus on the concept that if you are at higher risk, you're going to get screened earlier. This one is very high yield, especially for OBGYN shelf, starting at the age of 21 up until the age of 65. You are going to be screening for cervical cancer. Remember that with screening for cervical cancer, it is going to be every 3 to 5 years. And we will be going through the nuance. And that is that at age 30, you can get co-testing with HPV as well as the cytology. We're going to cover that a little bit later on. But remember, cervical cancer screening in majority of females at age 21. There's also a recommendation to screen young adults less than 24 years of age who are sexually active for STIs. This is going to be true, especially if the patient or young adult requests the STI screening or they have an active STI. So there's a UWorld question that talks about a patient who has gonorrhea. Well, if they have an active STI, we need to be screening for chlamydia, syphilis, HIV, etc. Starting at the age of 35, no matter the risk, you should be screening for diabetes as well as dyslipidemia. So you will get a fasting hemoglobin or fasting lipid screen. You will get a fasting blood sugar and a hemoglobin A1C. At the age of 40, there is a cardiovascular intervention, and that is going to be aspirin prophylaxis. This is going to be starting at the age of 40 in select populations. Those populations that are going to have an ASCVD or cardiac calculated risk of greater than 10%, those patients who do not have a bleeding risk, and those patients who are going to have at least a 10-year life expectancy. So what is important for us to note is that if the patient in the vignette has thrombocytopenia or has a GI ulcer, you do not want to give aspirin because they are at higher risk of bleeding, and thus you don't want to start a COX inhibitor that will reduce platelet aggregation and activation. At age 40, you also are going to be having the females get screened for breast cancer via mammography. age 40 to 74 years old, you do breast cancer screening every 1 to 2 years. Starting at age 45 till the age of 75, you're going to be doing colon cancer screening. There are some nuances, but colonoscopy is preferred. There are alternatives such as stool-based testing or something like a sigmoidoscopy, which we'll cover a little bit later on. From age 50 to 80, if the vignette mentions long-standing smoking greater than 20 pack years, you will be doing a low-dose chest CT scan to screen for lung cancer. Remember, a low-dose chest CT scan is not going to have any contrast-based medium. At age 55, there are recommendations to consider PSA screening. I will say that this has fallen out of favor, but I put it here for completeness sake. Starting at age 55, PSA can be screened. Digital rectal exam is now out of favor for prostate cancer screening. Wrapping up here, we have age 65. At age 65, if the patient is going to be a smoker or has ever smoked, has a history of smoking, then they will be screened via abdominal ultrasound for an abdominal aortic aneurysm. This is from 65 to 75. It is a one-time screen. And what you want to note is that regarding your AAA screening, that is a one-time screening, whereas the lung cancer screening is usually going to be yearly. Compare and contrast those two. Starting at 65, females especially will be undergoing osteoporosis screening. What is important for us to know is that at less than 65 years of age, if the female has menopause or any other risk factors, you can do a bone mineral density scan, which is going to be a DEXA scan. Typically, the DEXA scans are going to be repeated based on your T-score. It can be anywhere from 3 to 10 years. And the USMLE doesn't necessarily help make you tease those intervals out for osteoporosis screening. Now, the prior recommendations, before these last week recommendations came out, emphasized that if the patient is less than 65 years of age, they can be stratified using a fracture assessment score. And this is the FRAX score. But what these new guidelines just said were you can use the FRAX score, but it is not mandatory. So less than age 65, if in the vignette you see that the patient has celiac disease, is on prolonged glucocorticoids, or had menopause at age 50, you can consider osteoporosis screening via DEXA. So just to emphasize the high yield ones here, breast cancer screening starting at age 40, aspirin prophylaxis starting at age 40, colon cancer at age 45. Smokers are going to, at age 50, get lung cancer screening, are going to get abdominal aortic aneurysm screening at age 65. Osteoporosis screening starts at age 65, however, can be younger if there are going to be risk factors. So I just like to draw this little schematic here for myself. And AAA stands for abdominal aortic aneurysm. You have lung cancer that is going to be starting at age 50, whereas your abdominal aortic aneurysm, abdominal ultrasound is going to be at age 65 years old. Again, I want to emphasize before I move on that the USMLE makes these questions extremely obvious. The other point that I want to make here is the fact that the USMLE is starting to add in transgender health questions. And what I note here is that if there is a transgender individual that has not had genetic modification surgery, you will follow their cisgender or the gender that they were assigned at birth screening guidelines. And again, these are very sensitive conversations. However, you do want to keep in mind the cisgender screening guidelines for any transgender individual. All right. This is dense, but you know what we're going to do now? Keep this open, take a screenshot. We're going to be now applying it to different vignettes. Let's go ahead and go through this first NBME question to apply our diagram. Are you guys enjoying this review so far? Everybody doing okay? Go ahead and type in yes into the chat box. Excellent. I want to definitely just like break it down for you all, make it fun. Let's go ahead and go through this high yield vignette. A 42-year-old woman presents for follow-up after recently being treated for a urinary tract infection with antibiotics. During her visit to the emergency department, she was informed that her blood pressure was, quote, mildly elevated. She has no current symptoms, a significant medical history, or regular physician visits. Her family history is unremarkable, and her lifestyle is pretty active. She jogs twice weekly. She maintains a healthy diet. She's not on any medications. So what these all are pertinent negatives. They should rule you away, saying that she is a relatively healthy female. Her blood pressure today is 142/91, and her BMI is 28. Physical exam, EKG, and laboratory results, including a basic metabolic panel, are all normal. Again, another pertinent negative. Which of the following is the best next step in managing this patient? A, advise weight loss. B, obtain multiple home blood pressure readings. C, obtain polysomnography. D, start double antihypertensive therapy. Or E, start a single antihypertensive agent. What do you think is the best answer here? Excellent. Well, this concept basically tells us that you need to have confirmatory screening for blood pressure. It's not correct to just do a single blood pressure screen and say that you have hypertension, because there's that phenomenon known as white coat hypertension. The other thing to note is that in the emergency department, anybody's blood pressure can be elevated. So you want to do this essential hypertension screening when the patient is well. This is going to be a phenomenal slide for you to save. This goes through not only the definition of hypertension, however, what are the ways we can confirm the diagnosis? So definitions of hypertension: blood pressure greater than 140/90 is generally accepted. There are some health bodies, such as the American Heart Association, that lower that threshold. In pediatric patients who I work with, we typically, in patients less than 13 years of age, look at the normative guidelines of those patients and their blood pressure. And if they are going to be greater than the 95th percentile for their blood pressure, we diagnose hypertension. Now, white coat hypertension is a phenomena. And this is this concept that if the patient is in the doctor's office, they could get a 5 to 10 millimeter of mercury higher reading in the office. So in this patient, the patient was 142/91. And what we have to do is confirm the diagnosis of hypertension. So what are the ways we can confirm it? The first way is going to be an ambulatory blood pressure cuff. This is going to be a wearable device that the patient can wear, and it squeezes their arm every hour or so, and they can wear it for about 2 days and get those readings. Second, you can do home blood pressure monitoring. This is where you can say, Grandma, go ahead and measure your blood pressure in the morning and in the afternoon for a week. And if there is a trend of increased readings, then we can diagnose the patient as hypertension. And then finally, if the patient is unable to do home monitoring or ambulatory monitoring, you can bring them back to the office for at least 3 occasions, 1 week apart, to diagnose hypertension. Again, the point here is that you need to have confirmation rather than a single blood pressure reading. So let's say in your vignette, the patient is diagnosed with essential hypertension. What are going to be the next tertiary prevention components which you do need to get? Well, you need to get a renal function panel. You need to look at the kidney function. What are the electrolytes looking like? What is their BUN to creatinine ratio? What is going to be their UA? Does it show any signs of end organ damage like proteinuria? When somebody gets diagnosed with hypertension, you also must think about endocrinological causes and screenings. You may want to get a hemoglobin A1C because hypertension, dyslipidemia, and your dysglycemia is going to be associated with metabolic syndrome. Patients may also get a thyroid function panel. Finally, you could also consider further cardiac testing after you have a patient with new diagnosis hypertension. Usually patients will get an EKG, but there's an increasingly push to also get an echo. Again, why is this? Because if you think about hypertension, it is going to be a chronic afterload state. If it's a chronic afterload state, what's the structural complication? Left ventricular hypertrophy. And so what we want to do is look at the EKG for any voltage criteria or the echo just showing the thickness as a baseline of the left ventricle in particular. What is also highly tested on your shelf exam questions are secondary causes. So basically, this is going to be, these are going to be vignettes related to the patient having a high blood pressure, and then you extrapolating what could be other pathophysiologies or diagnoses the patient could have. For example, if they put Brui on physical exam, you're worried about renal artery stenosis. If the patient has hypertension and hypokalemia, that's very important. You may be considering some elevation in the renin-angiotensin-aldosterone system. Maybe it's an aldosterone-secreting tumor. If the patient is going to have symptomatology such as weight gain, abdominal striae, poor wound healing, you may be thinking about Cushing's disease. And remember, these patients can also have hyperglycemia. If the patient has paroxysms of hypertension, headache, pallor, you could be thinking of a sympathetic tumor like pheochromocytoma. And then another one that I find extremely high yield is going to be obstructive sleep apnea. Remember, OSA is going to cause you to have increased CO2 throughout your body. That can then cause you to be in a very stressed state, elevating your systemic vascular resistance, leading to hypertension. I also like to note with OSA that patients on your vignettes are going to have morning headaches. And also, they are going to have potentially a reactive polycythemia. And that means that their hematocrit may be low because they could be chronically hypoventilating. That then is going to have the kidney sense, oh gosh, there's probably low oxygen throughout the body, and thus it's going to upregulate the amount of erythropoietin, thus increasing your hematocrit. All right. So with that, I'm going to ask another application-based question. This is important for us to go through. Please stick with me. Stay inspired, stay active, stay engaged, cut out all your distractions. Here we go. A 58-year-old man with type 2 diabetes presents for routine follow-up. His medical history includes hypertension and diabetic kidney disease. He is currently on metformin, lisinopril, atorvastatin. His blood pressure is 138/82. His most recent hemoglobin A1C is 7.8. Laboratory results show a GFR of 45, a elevated urine albumin to creatinine ratio. What do you think we could do to reduce the progression of the kidney disease? Pay attention to the STEM. A, aggressive lipid management. B, switch lisinopril to a calcium channel blocker. C, a low protein diet. D, add SGLT2 inhibitor like canagliflozin. Or E, aspirin therapy. What does everybody think is the best answer here? Go ahead and type it into the chat box. Excellent. In this patient who is going to have diabetes plus hypertension, the USMLE wants you to know that you need to have patients on ACE inhibitors. That's why B is going to be wrong. Remember that if we go back to a high yield concept from Pathoma, what Pathoma basically teaches us is that here is going to be the glomerulus, afferent, efferent arteriole, If you have diabetes, you get preferential non-enzymatic glycosylation of the efferent arteriole. That then is going to cause a glomerular stress that can expand the mesangium, known as Kimmelson-Wilstein nodules. And then you can have increased glomerular capillary hydrostatic pressure that can lead to microalbuminuria and subsequent macroalbuminuria. So what ACE inhibitors are going to do is they are going to dilate the efferent arteriole. And as they dilate the efferent arteriole, you're going to get less mesangial stress and less of the microalbuminuria. So it is protective. But what we also want to do is we also want to make sure we have aggressive control of the underlying cause. And that is aggressive control of the diabetes. Usually we want to, for these high-risk patients, make the hemoglobin A1C less than 7%, because that then is going to reduce the progression of the kidney disease. So an SGLT2 inhibitor is going to make you pee out a lot of glucose and then hopefully reduce the serum glucose levels over a long term. And thus you can make your 7.8 closer to that ideal 7 target. All right. So as we continue to break down our framework today, I want to provide you a test-taking strategy that you can use whenever you get a screening question. Number one, you have to note that many USMLE Step 2 CK questions have patients in the office setting. They're going to say a 55-year-old male presents to the office for routine health evaluation. Just pay attention to the fact that screening questions usually are asked in the office setting. Second, here's going to be the test-taking framework I use. Number one, localize the age. I usually never use age as a basis for my diagnosis. However, what I do focus on is age if they are going to be asking me a preventative health question. You want to also identify risk factors, as you saw in prior questions and in that summary diagram. If the patient has a history of obesity or the patient has a family history that's relevant, that could change your screening guidelines. And then finally, what you will do, and this review helps you here, is apply the USPSTF guidelines. All right. So let's go ahead and go through 3 cases to solidify our knowledge. A 68-year-old male with COPD presents to the office for routine health maintenance. So remember, he's 68. He began smoking at age 18, so a long-standing history of smoking. However, he has quit in the past 10 years, so he quit at age 58. What screening exams would be indicated in this patient? I'm going to pause right here. I want you all to go into your diagram, isolate what this patient would need in terms of screening, and type your answer into the chat box. Very good. So screening exams that would be indicated: lung cancer screening, as well as abdominal aortic aneurysm screening. So let's go ahead and go through this in a little bit more depth. So this patient is going to require low-dose chest CT scan and AAA surveillance screening. Lung cancer screening guidelines, here we go. It starts at the age of 50 up to the age of 80. It is going to be for patients who have greater than 20 pack year smoking history. As you can see, he began smoking at the age of 18 and he is 68 years old. This is going to be a yearly interval. Remember, AAA is usually a one-time, whereas lung cancer low-dose chest CT is going to be at a yearly interval. And you are going to terminate screening either at the age of 80 or if the patient has successfully quit for greater than 15 years. And as you can see in this vignette, the patient quit in the last 10 years. So he still does need lung cancer screening for the next 5 years if he continues to successfully quit for a total of 15 years. So I want to provide an epidemiology integration. Obviously, we all know the health risks related to smoking, but remember that smoking cessation really reduces the risk of lung cancer. On the contra, if you are going to have a patient that is going to have a heavy smoking history, the probability of lung cancer in this hyperbolic relationship is going to go up. What is really important for us to know is that if the patient even just quits for 5 to 10 years, the patient has a 50% less risk of developing lung cancer. And what's also interesting for us to know is that if the patient quits for more than 15 years, the risk of lung cancer is the same as if you had not smoked ever. And so that's probably one of the rationales as to why you stop when the patient has successfully quit greater than 15 years of age. Smoking is a very important risk factor. In my Step 2 CK course, I have a whole set of videos just focus on risk factors because I think they're so high yield. Let's go through the various risk factors related to smoking. The one that is highly tested is pancreatic cancer. This in your vignette usually presents as painless jaundice. You also want to note that smoking is going to affect blood vessels. So it could be a risk factor for subarachnoid hemorrhage or aneurysms within the brain. Smoking is going to connect or contact with your oropharynx, and thus you can have smoking as a risk factor for head and neck cancers. Smoking is also going to be a risk for oral cancers, especially because the smoke is going to enter the mouth, and then that can cause you to have carcinogenic mediated damage, and you can have cervical lymphadenopathy that can occur, or submandibular lymphadenopathy. Smoking is also going to affect the esophagus. Just think about how the smoke is coming in. It's a risk factor for squamous carcinoma in particular. It also is going to be an increased risk for blood vessel complications that can lead to abdominal aortic aneurysms. Again, smoking causes endothelial injury that can break down the tunica media, and thus you can have an aneurysmal dilation. Smoking is going to be a risk factor for renal cell carcinoma as well as bladder cancer, because remember, the smoke or the polycyclic hydrocarbons are going to be excreted via the urinary system. So it is going to come into contact with the renal and the bladder tissue. Remember that pancreatic cancer presents as painless jaundice, whereas bladder cancer usually presents as painless hematuria. So here's a basic science integration for us. Smoking is a cellular stress, which can cause a histological change that can lead to neoplasia based on the metabolism of polycyclic hydrocarbons. These are the things that are carcinogenic. They cause free radical injury as well as endothelial injury, and that's why it compromises the blood vessels. All right, same patient, 68 years old, has COPD. He started smoking at 18, has successfully quit in the last 10 years. That's great. Another screening that he would need is a abdominal aortic aneurysm screening via abdominal ultrasound. Now, this starts at the age of 65, and as you can see, he is 68 years old. The abdominal aortic aneurysm guidelines say ever smoking. So I was like, man, if you just tried smoking once, you have to get this? No, it is ever smoking is defined as greater than 100 lifetime cigarettes. Abdominal aortic aneurysm screening is a one-time compared to your low-dose chest CT, which is going to be yearly. You're going to repeat it based on the size, especially if the size is greater than 5.5, which is going to be a threshold as to when we are going to repair the abdominal aortic aneurysm. If the size is close to that number, you may come back in 6 months. But the USMLE doesn't get too nuanced in terms of the screening interval. They just want you to recognize an abdominal aortic aneurysm, either asymptomatic or one that has a bruit that is large enough, greater than 5.5 centimeters, that for your surgery shelf questions, you need to repair. So let's go ahead and do a compare and contrast between lung cancer screening and AAA screening. Lung cancer screening starts earlier, 55 till age 80. It is going to be patients who have greater than 20 pack year smoking history at a yearly interval, and you're going to terminate at age 80, or if they have quit for 15 years, because now the risk comes back to the non-smokers. AAA screening, you're going to be thinking of ages 65 to 75. It is going to be provided in ever smokers via abdominal ultrasonography. It is usually going to be a one-time, and if it is getting closer to the 5.5 threshold, you may want to screen a little bit early in frequent intervals, tell the patient to come back in 6 to 12 months, and at the 5.5 centimeter mark, or if the patient is symptomatic, you are going to be considering repair. All right. Another very high yield screening guideline is going to be colonoscopy. Go ahead and type into the chat, what is going to be the general recommendation for colonoscopy? What age does it start? Go ahead and type that into the chat. Excellent. If you are going to be saying greater than the age of 45, you are absolutely correct. So typically it's going to be age 45 to 75. And can you go ahead and type into the chat, what are some alternatives from your colonoscopy where you get a bowel prep and you see the whole colon? What are some of the other alternatives? Excellent. Very good. So flexible sigmoidoscopy can be performed every 5 years. You could get a CT colonography. That is also going to be at a 5-year interval. And then if you do stool-based testing via fecal occult blood or a immunoassay, the FIT test, any stool-based testing where you poop and put it on a card is going to be every year. Remember that the FOBT, which is going to be the occult blood test, that is going to detect heme, whereas the immuno test is going to detect the globin from the hemoglobin. And you can also combine that with DNA testing as well to, again, get a little bit more sensitive. Typically, the USMLE is going to test you on the colonoscopy guidelines only. However, if you have a first-degree relative, let's go through this vignette. A 35-year-old patient has a brother who was diagnosed with colorectal cancer at age 52. When does this patient need screened? Go ahead and type it into the chat. When does this patient need to be screened? So many of you are saying 10 years before the diagnosis of the brother. That would be 42. However, I wrote this question strategically. The answer is actually going to be colonoscopy at age 40. Why is that? Because remember, the guidelines are age 40 or 10 years before the age of diagnosis of the first degree relative, whichever comes first. And in this case, it could be 42 or 40. What comes first? It is going to be 40. So that's why you start this patient screening at age 40. So again, whichever comes first, that's why I placed this beautiful question in. What's also important for us to know is that if you have a first degree relative, you may end up screening or repeating the screen every 3 to 5 years because these patients may be at high risk. All right, let's go ahead and go through this question. Is everybody enjoying this review? Everybody doing okay? All right, very good. Thank you so much. A 52-year-old woman undergoes colon cancer screening with colonoscopy. During the procedure, a 4-millimeter polyp is identified in the sigmoid colon and removed. Histopathological examination reveals that this is a 4-millimeter hyperplastic polyp. There are a lot of pertinent negatives here. No family history, no smoking, no alcohol, no other significant medical history. Which of the following with this hyperplastic polyp is the most appropriate screening recommendation for her next colonoscopy? Go ahead and type your answer into the chat. Excellent. If you are saying repeat in 10 years, you're absolutely correct. The key concept here is that small hyperplastic polyps do not change the interval of screening. So you are going to, again, start at the age of 40 and then just continue to move forward from there. Excuse me, start at the age of 45. I apologize. And you will do it every 10 years if you just see a small hyperplastic polyp. It does not change the screening frequency. All right, let's go through this one. A 23-year-old male recently was diagnosed with ulcerative colitis. When would the patient require colorectal cancer screening via colonoscopy? So this is a nuanced one. And what you want to know is that it is usually going to be 8 years after diagnosis. So in this case, the patient will be screened at the age of 31 because that is 8 years after the age of 23. The other point we want to note is that these patients are going to also be screened when they develop primary sclerosing cholangitis. So if they develop PSC, which typically presents as an ulcerative colitis patient who is going to have increased bilirubin, itchiness, jaundice, and cholangiogram showing this beating of the gallbladder tree, indicating that there is going to be some sort of inflammation, what we call onion skinning fibrosis of the intra and extrahepatic structures. You then will start doing screening at the time they develop PSC. Remember, you want to know that these patients with IBD, they will not only start 8 years post-diagnosis, but you're going to repeat it every 1 to 2 years. All right, next one. Let's say the patient is going to have a family history of the APC gene mutation. When do you screen? When you have a predilection towards familial adenomatous polyposis. That is going to be very young, starting at the age of 10 years. You're going to start doing screening colonoscopies. So anytime you have a chronic disease, let's say that you have, for example, ulcerative colitis, FAP, Lynch syndrome, you typically are going to do yearly colonoscopies, especially for familial adenomatous polyposis. They are at high risk for developing colon cancer. All right, Lynch syndrome. A patient with family history of ovarian cancer and MSH1 mutation. Remember, Lynch syndrome is hereditary non-polyposis colonic carcinoma. It is going to be due to issues with microsatellite instability. When are you going to start? You're going to be starting at the age of 20 years. And you're going to repeat colonoscopies every 1 to 2 years because chronic diseases get a repeat colonoscopy every year. So just to compare and contrast, when we think about the FAP, that is going to be at 10 years of age, whereas Lynch syndrome is going to be 20 years of age. All right, let's go through this next question. A 68-year-old postmenopausal female presents for routine health maintenance. She had a colonoscopy less than 5 years ago. She is a non-smoker. She exercises 4 times per week. What screening exams would be indicated in this patient? Excellent. If you are talking about osteoporosis screening as well as mammogram, you are absolutely correct. Very good. So let's go ahead and understand this a little bit more. Remember that this patient is 68. So cervical cancer screening is usually going to stop at 65 years of age. And so that's why the patient does not need a pap smear. For breast cancer, you typically are going to start at age 40. And you are going to end at age 74. So not only does this patient need a DEXA scan, but also needs a mammogram. So let's review the mammogram here. Mammography is going to be indicated in females greater than the age of 40 up until the age of 74. And this gray zone is between ages 40 and 50. Now, there are recommendations to potentially start at 40, but the USPSTF says that there is definite benefit, no matter what, at age 50 to start mammograms. This is typically going to be done every 2 years, and you want to pay attention to risk factors in your vignette, specifically age being a very non-modifiable risk factor related to breast cancer, increased estrogen exposure. Let's say that the patient was nulliparous, has not had any progesterone cycles. Let's say the patient had early menarche or late menopause. And if the patient has a first-degree relative, likely you're thinking of BRCA. Remember, first-degree relative isn't that third cousin. First-degree relative is mother, sister, brother. All right, let's go ahead and go through this high-yield question. A 55-year-old woman, G2P2, comes to the office for a routine health maintenance exam. Menarche was at the age of 15, and menopause occurred 4 years ago. The patient used vaginal estrogen cream twice weekly for the first year after menopause, but currently takes no medications and takes no allergies. A paternal aunt died of breast cancer this year. Again, not first-degree relative. The patient is concerned about her own risk for breast cancer. Her BMI is 24. Everything else looks pretty normal. Which of the following confers the greatest risk for breast cancer in this specific patient? Is it A, age at first pregnancy, B, age at menarche, C, current age of the patient, D, family history of breast cancer, or E, use of vaginal estrogen for 1 year? What do you think is the best answer here? Excellent. Remember, age is the strongest risk factor. If the patient was nulliparous or the patient had menarche at a very young age, let's say 10 years or younger, then that would probably be a higher risk factor. But in this case, the patient's age is the greatest risk factor for developing breast cancer. Another high-yield question that comes up on NBMEs is the evaluation of a palpable breast mass. Now, guys, I'm going to make it very simple for you all. When you see a palpable breast mass, just pay attention to the age in the vignette. If the female has a palpable breast mass and the patient is less than the age of 30, then you're going to be doing an ultrasound. This is because ultrasound is going to expose the patient who is young to less radiation. And second, the breast tissue is very dense, so ultrasound is going to pick that up. Whereas greater than the age of 30, you're going to be doing your mammogram if you have a palpable breast mass. And that is in alignment with probably they're getting closer to screening. So if you have a palpable breast mass, these females are going to be older. They can handle the radiation and they are going to have less dense breast tissue. And thus, a mammogram can be advised in those patients with the palpable breast mass. So same patient here. Many of us said that she also needs a DEXA scan. So let's go ahead and go through the high yield components for a DEXA scan. Osteoporosis is going to be screened via bone mineral density. It is going to start at the age of 65 years, every 3 to 10 years. There's no real recommendation or indication to do it less than 3 years apart. So the lowest threshold is going to be every 3 years. But again, it is all dependent on what your T-score is going to show. If the female is less than 64 years of age, you can use the FRAX score, but the new guidelines say that it's not necessarily mandatory. The FRAX score is a fracture assessment risk score, and that is going to give us a calculated score of the 10-year risk of developing a fracture, like a hip fracture, for example. So what's important for us to know here is that what is all in the FRAX score? What makes a patient at risk for a fracture? Well, it would be glucocorticoids, active smoking, a rheumatologic disease such as rheumatoid arthritis. Remember that if the patient has rheumatoid arthritis, they are going to have a lot of inflammation. And inflammation is going to reduce the trabecular meshwork of the bone. And then anything that is going to cause secondary osteoporosis. And guys, this is super high yield. Think about it like this. if the patient is going to have any sort of duodenal disease, such as celiac disease or Crohn's disease, or if they have any pancreatic disease in which they cannot reabsorb fat-soluble vitamins, such as vitamin D, you are going to be at increased risk for weak bones, i.e. secondary osteoporosis. So always think about those past medical histories, celiac, Crohn's, and pancreatic insufficiency, as well as hyperthyroidism. Similar to rheumatoid arthritis, a lot of thyroid hormone is going to reduce the trabecular meshwork of the bone. So I do want to integrate a basic science tie-in here, and that is the discussion of rank and rank ligand. So remember that parathyroid hormone is going to be released from the parathyroid gland, and it's going to tell the osteoblast to release rank ligand. That binds the rank receptor on the osteoclast, and thus the osteoclast gets activated. Remember, the osteoclast is from a monocyte lineage, and then the osteoclast starts chomping on bone. But there's also a very important chemical, and that is going to be known as osteoprotogerin. Now, osteoprotogerin is going to, and I'll do it in pink, inhibit rank ligand. So if it inhibits rank ligand, it prevents rank from binding to the rank receptor, and thus you are going to have more protection of the bone. Why is that? Because osteoclasts aren't going to be activated. So the goal here is to recognize that a high osteoprotogerin is going to protect the bone. Very important. And how does it do that? It is going to inhibit the rank receptor. Now let's go through this. When we are thinking about estrogen, guess what estrogen does? It is going to increase osteoprotogerin, and it is going to reduce rank ligand. So estrogen makes the osteoblast stronger and inhibits the osteoclast. And that's why estrogen is protective to the bone. Now, like I mentioned, the key definitions here are for us to recognize that the T-score is what we are going to utilize for our DEXA screening in particular. Now, the T-score compares the patient to the peak bone mass of a younger adult counterpart. It is going to compare the peak bone density of somebody of a younger age, but similar sex and gender, or similar race and gender. What's important for us to also know are these definitions. What is it known as? Go ahead and type into the chat. If the patient is going to have a T-score between -1 to -2.5, go ahead and type into the chat. What's the diagnosis then? Excellent. If you're saying osteopenia, you're absolutely correct. What about if the patient is going to be less than 2.5? That is going to be osteoporosis. And remember, it's less than -2.5. So that means a more negative number tells you you have a deviation from the peak T-score, and thus you are going to have weak bone, i.e. osteoporosis. So the USMLE loves for you to know what are the risk factors related to osteoporosis. You have non-modifiable, which you can't control, and modifiable, which you can control with lifestyle modification. Non-modifiable are going to be things like age, postmenopausal status, and low body weight. Remember, weight-bearing exercise is actually good for patients. Other non-modifiable risk factors for osteoporosis is going to be a white or Asian race. This is going to be a condition where African-American race is actually protected. We talked about non-modifiables such as malabsorption diseases like Crohn's and celiac, as well as inflammatory conditions like rheumatoid arthritis. Chronic inflammation weakens the trabecular meshwork. Now, modifiable risk factors are things like smoking, if you're drinking a lot of alcohol, or you have a sedentary, non-weight-bearing lifestyle. What's also important are going to be other modifiable risk factors. For example, if you are vitamin D deficient, that can lead to osteoporosis. So that's why we treat with a high calcium and a vitamin D supplement. And then finally, medications can actually lead you to osteoporosis. Go ahead and type into the chat, what is one medication that can cause secondary osteoporosis or a weakened bone. What do you guys think? And we're almost done with this review, so please stick with me here. Excellent. If you are going to be saying corticosteroids, you're absolutely correct. So here we have a vignette, a female who presents with a medication-induced osteoporotic fracture. I'll tell you here that what they say with the osteoporotic fracture is the female has sudden back pain and point tenderness, indicating if they have point tenderness to the vertebral body or the lumbar, the spine, you're going to be thinking of a compression fracture. And that's important for you to know that that typically presents with point tenderness. All right. So anti-seizure medications can cause you to have osteoporotic fractures. Why is that? Because anti-seizure medications induce CYP450 and can increase the breakdown of vitamin D. Aromatase inhibitors are going to cause you to have osteoporotic fractures. Why is that? Because remember, aromatase like anastrozole, letrozole, they are going to reduce the conversion from testosterone to estrogen. And thus, if you have less estrogen, you have less protection of the bone. GnRH agonists, such as leuprolide, especially if they are going to be given in a continuous manner, will reduce the pulsatile nature of testosterone and estrogen release. Glucocorticoids, you may want to put a star here. They'll give you a patient who has a chronic refractory autoimmune disease. They're on chronic steroids. They can push the questions towards more Cushing's, or they can say secondary osteoporosis, because what glucocorticoids do, they're exact opposite of estrogen. Estrogen increased osteoprotogerin, whereas glucocorticoids reduce osteoprotogerin and reduces the osteoblastic activity concurrently. Omeprazole is going to inhibit calcium absorption. And so long-standing omeprazole use can actually lead you to osteoporotic fractures. I also want to go through some high-yield pharmacology. This is going to be very important because the USMLE loves for you to know the various medications that we use to treat osteoporosis. Let's go through a few of them. The first one is bisphosphonates. Remember that they have the suffix dronate, alendronate, for example. They are usually going to be first line, and the key guidance that you want to give patients is you want them to take it with water and take it upright, because there is a question that I've seen on NBMEs where they talk about a patient who has difficulty swallowing after bisphosphonates. Go ahead and type into the chat, what is the side effect if the patient had difficulty swallowing after taking alendronate? Excellent. If you're saying pill-induced esophagitis, you're absolutely correct. You could have elevated eosinophils, and long-standing, you could have strictures. The other thing that the USMLE wants you to know is that bisphosphonates are associated with osteonecrosis of the jaw. Another medication for osteoporosis, denosumab. This inhibits rank ligand. Hey guys, we talked a lot about rank ligand. If you have forgotten it, please refer to the prior portion of this lecture, which goes through the interaction of osteoblasts and osteoclasts. Teriparatide is another osteoporosis medication. Teriparatide, you can see or derive PTH. So it is PTH-like, and thus it activates osteoblasts. Nasal calcitonin can also be used. Again, calcitonin is going to be contra PTH or complementary to PTH, and it has been shown to reduce pain in compression fractures. Remember how compression fractures present: point tenderness to the vertebrae. And then finally, selective estrogen receptor modulators, such as raloxifene. Raloxifene, I like to think of the mnemonic, hey, put a Rolex on your wrist. That tells me that raloxifene not only is going to help be an antagonist to the breast estrogen receptor, but it's an agonist to the bone. So it reduces the risk of breast carcinoma, but it is protective for osteoporosis. And just remember that it does carry a side effect because it is an estrogen receptor modulator of hypercoagulable state. So patients on SERMs can have an increased risk of DVTs. A 25-year-old female presents for routine screening. She is sexually active. She has no past medical history. She takes no medications. Oh my gosh, she requests STI screening. So in addition to getting a wet mount for trichomonas, making sure that we screen for gonorrhea, chlamydia, syphilis, HIV, what other screening tests would you provide to this 25-year-old female? Excellent. This is our last case, and that is going to be related to cervical cancer screening. Now, cervical cancer is caused by HPV. There are low-risk strains and high-risk strains. What are the low-risk strains? 6 and 11. High-risk strains, 16 and 18. Very important for you to know. Now, HPV screening, let's go through this. It starts at the age of 21, and between the ages of 21 to 29, you can just do cytology every 3 years. However, at greater than the age of 30, you can do cytology every 3 years, similar to what you did in your 20s, or you can do cytology plus co-HPV testing for all those strains, and that will be every 5 years. So that is extremely high yield for you to know, is that co-testing starts at age 30. But there's a nuance here. And that is if the patient is going to be getting on their pap smears atypical cells of undetermined significance, what we call ASCUS, you will start HPV testing not at 30. You can start it as early as 25. And the USMLE loves for you to know that. They'll bring a patient for pap smear, and now the patient got a pap smear. It showed atypical cells of undetermined significance. You will then look at the age, and if the patient is like 26 years old, you'll say, all right, I'm going to do HPV testing, but the guidelines say 30. But this patient has ASCUS. So ASCUS makes you do HPV testing a little bit earlier. Now, the other thing for us to know is that let's say on your OBGYN shelf, you have a pregnant female who comes in, hasn't seen the doctor in many years, but she's pregnant. Congratulations. You can do pap smear during the first visit. When you're going to start drawing all the labs, RH, et cetera, for their first prenatal visit, you will do a pap smear if they are due at that time. All right. We have a 19-year-old female who was found to be HIV positive. She was diagnosed with lupus 2 years ago and is on immunosuppression therapy. In the past year, she has become sexually active. Go ahead and type into the chat, would a pap smear be recommended in this patient? Again, HIV diagnosis, immunosuppressed, but she's 19. The answer is yes. What is high yield for us to know is that there are high-risk populations, HIV, as well as any sort of disease that you're on immunosuppression. You are actually going to start pap smears much younger than 21, i.e., you're going to start at the onset of sexual intercourse. And you're typically going to do an interval every 6 months times 2, and then you'll move to annually. And this is extremely important because what's high yield here is to recognize that, remember, you have the endocervix, which is going to be columnar, and then you have the ectocervix. And the ectocervix is going to be squamous. A pap smear usually is going to hit this transformation zone because just from pathoma, we learned that HPV, which is a virus, is going to affect this transformation or transition zone between endo and ectocervix. But what's also important for us to integrate here is the immune response to HPV in this area. And the immune response for HPV is T cell mediated. You need, for example, CD8 positive T cells to kill HPV. But if you have HIV, let's go through the pathophysiology. You don't have good T cells. So you have more susceptibility, especially with HPV being a contact-mediated disease. You have more susceptibility for HPV to affect your transformation zone, leading to, if you have high-risk strains, leading to cervical cancer. And that's why anybody with the T cell immunodeficiency needs HPV screening. The other thing for us to note here is that HIV screening, which is going to be 4th generation, antibody and antigen, that in your USPSTF guideline is going to be recommended as early as age 15. And so, hey, she's been sexually active. You may want to do a HIV screening. And remember, for your peds shelf, if the mom had HIV, you need to, in the infant or neonate, you need to get a nucleic antigen test, or basically the quantitative number of the HIV in the blood for that neonate. And usually those neonates with HIV positive moms, the next best step in management the NBME likes to go for is start treatment with zidovudine, which is going to be a antiretroviral therapy agent. And now we have come to the end of our session. Let's go through a few rapid review. I want everybody to go ahead and put your fingers on the chat box, please. Here we go. What ages do you start AAA screening? Go ahead and type that into the chat. Yeah, one-time screening, age 65 to 75, who have ever smoked. All right, next question. 33-year-old female presents for routine health screening. If she wants to come back in 5 years for her pap smear, what screening test needs to be initiated? What do you think the answer is here? Excellent. If you said co-testing with HPV cytology and DNA, you're absolutely correct. When should children receive oral fluoride? This is interesting. It's going to be the first tooth eruption in areas where there's low fluoride in the water, which they'll never really test. It's as early as 6 months, but it's typically going to be first tooth eruption in areas where there is good fluorinated water. A 14-year-old male presents to the adolescent clinic. He is frequently teased due to his acne. What is an appropriate screening recommendation for this child? And that is going to be depression screening, starting as early as the age of 12. A newborn baby is leaving the delivery room. What antibiotic therapy is indicated in this patient? Yep. When I was a peds resident, I would, after I resuscitated the baby, if the baby was healthy, just go ahead and do eyes and thighs, which means that you do the erythromycin eye drop for prevention of gonococcal ophthalmia neonatorum. And then thighs. What was the thighs for? What did I inject in the thighs? Vitamin K. Yep, exactly. Because these babies need vitamin K due to their immature liver, and they need to develop their clotting factors. All right, last slide of the day. What age should you start colon cancer screening? Excellent. If you say 45, you are absolutely correct, up until the age of 75. A very compliant patient is due for his first low-dose chest CT. What is the likely age of this patient? Excellent. If you're saying 50 years old, you're absolutely correct. And make sure that it is a long-standing smoker. A patient had a friend who was recently diagnosed with the AAA after the doctor heard a bruit. What age should this patient, who is an active smoker, be screened at? Excellent. One time at 65 years of age, and then you stratify based on size. I want to end with this wonderful quote that I was reading as I was preparing this webinar, and that is, an ounce of prevention is worth a pound of cure. So as you go to your clerkships and you practice as a physician, remember those bottom parts of the pyramid, primary and secondary prevention, is so essential no matter what field you go into. I just want to say thank you all so much for joining me in this review. I want you all to stick around for a Q&A and some updated content that is in my Step 2 CK course 2025. My HyGuru course has these very nice case-based vignettes and multiple choice questions. Feel free to check out my Step 2 CK course at hyguru.com. It's an integrated way for you to go through the material. I also have embedded into the HyGuru Step 2 CK course a UWorld note-taking template. It is produced on Notion. Notion is kind of like an Evernote or Excel Word document. It's very nice. It's a template that many of my students have used to just categorize all of the UWorld mistakes in one place. In my opinion, it is superior to Anki cards because you have the ability to construct your own knowledge. And guess what? You also have the ability to create in a guided manner vignette-based notes. And so guess what I did for all of my lectures for the Step 2 CK course? I not only mapped it to vignettes or practice questions from UWorld, but secondarily, I have created vignette-based flashcards, and I'm going to be uploading them this week. All of the vignette-based flashcards underneath each video. So each video will have 3 or 5 flashcards that I wrote that, again, look at this, vignettes, 50-year-old headache, vomiting, papilledema, what is the likely cause of the ICP? And then bam, on the back, not only do you get the answer, but you also get a test-taking tip. So my goal is to create flashcards that are going to essentially force your mind to do higher levels of the thinking pyramid, critical thinking, application, appraisal, rather than just recall of random facts that maybe some low-level cards can do. If you've stuck around until now, I just want you all to smile, congratulate yourself. And if you feel that you gain something, share HyGuru to your friends, colleagues, your school. I would love to connect with each and every one of you. If you guys have not yet written a review, please do so. Just click this link right now. It takes about 5 minutes. I would be grateful for you to spread the word of HyGuru, one medical school at a time. My goal here is to elevate your preparation and provide you an active recall integrated way of learning. That's the end of today's webinar. Before you leave, type in one thing that you learned today, and then I will go ahead and go into a Q&A. Thank you for your time and attention.